Hello, everyone. I'm thankful to organizers of KSELS who have provided me an opportunity to present in front of such an august audience. I will start with the name of Allah, the most gracious, the most merciful. I'm Dr. Muhammad Imran Khokar, Associate Professor of Surgery at Gujranwala Medical College, Gujranwala, Pakistan. And I'm going to talk about minimal access thyroid surgery, our experience and recent advances. This is my team while I was working recently at Lahore General Hospital. And this is my team at my new place, Gujranwala Medical College. So we'll quickly go through the history of minimal access thyroid surgery. We'll see what are the indications, contraindications, what are different approaches. We'll talk about TOETVA and axillary breast shoulder approach. What is our experience about minimal access thyroid surgery, and we'll see what are recent advances. Then I will conclude. So going through the history, Dr. Michael Garnia was the first person who started endoscopic neck surgery, and he started for parathyroid gland in 1996. Here I'm with him at SAGE's meeting. Dr. Hushar in 1997, he successfully performed endoscopic thyroidectomy for B9 tumor in 1997. Dr. Paulo Macaulay, he started video-assisted thyroidectomy for papillary carcinoma of thyroid in 2001. Dr. Claire Long, he started axillary breast shoulder approach for endoscopic thyroidectomy in 2003. And he is my mentor as well. Dr. Anu Wong in 2012 started transoral endoscopic thyroidectomy vestibular approach in Thailand. So if we talk about indications and contraindications, these are almost the same as for open surgery, but depends upon the learning curve and experience of the surgeon. We operate on tumors of about 5 centimeters or less. Relative contraindications include locally advanced carcinoma, previous neck surgery, large size goiters, previous neck irradiation, and obviously the patient's result. If we talk about different approaches, these can be divided into cervical approach and extra cervical approach, also called hybrid approach. This is axilla, both breast approach, both axilla and breast approach, and axilla breast shoulder approach. Then we have transoral endoscopic thyroidectomy vestibular approach, transoral robotic thyroidectomy, and transaxillary gasless robotic thyroidectomy. In cervical approach, we can see that the ports are inserted directly into the neck that leave scar. Axilla breast shoulder approach, axilla both breast approach, one port is inserted in axilla and two in both circummedullary area. Both axilla are being used and both breast circummedullary area is being used. Axilla breast shoulder approach, 10 mm port in the axilla and 5 mm port in the ipsilateral areola, circummedullary area, and tip of the shoulder. Transoral endoscopic thyroidectomy vestibular approach, vestibule of the oral cavity is used. A 10 mm incision in the midline, transverse incision, and 5 mm incisions in front of canine teeth. Transoral robotic thyroidectomy, where robot is being used. Transoral gasless robotic thyroidectomy, you see, going through the axilla. So we are operating TOETVA, that is transoral endoscopic thyroidectomy vestibular approach, and axilla breast shoulder approach. Here we can see the same 10 mm incision in the midline and 5 mm incisions on the side in front of the canine. This is our patient. You see the nodule on the left side in lower part. Local anesthetic is injected at the site of incision. Incision is being made. Space is established in sublatissimal area, and 10 mm port is being inserted through the incision. Here we can see the 10 mm port and 5 mm ports at the side of canine teeth. This is external view after lifting a flap in the neck in sublatissimal plane. Endoscopic view, you can see that the muscles are being lifted above after dividing in the midline. The nodule is being exposed, and here the nodule is exposed, and dissection is continued. And after the dissection, the nodule is retrieved using a bag made by glove. So this is a nodule that is retrieved after surgery. This is how the wound is closed in the vestibule. And this is first post-op day after surgery. You can see scarless neck. So going through the axilla breast shoulder approach, we'll go through the steps in next slides. In this technique, 10 mm port is inserted through the axilla, then 5 mm port, circumarular area, and then 5 mm port at tip of the shoulder. First step is to identify the suprasternal notch. You can see the glistening white area. Second step is to identify the ipsilateral sternocleidomastoid muscle while lifting the flap in the neck. And here we can see that the nodule is covered with the strap muscles. This is external view after lifting flap in the neck. The nodule is being exposed using monopolar diathermy and splitting the strap muscles. Nodule is exposed now. Superior pole dissection using the harmonic scalpel, and then preserving the superior parathyroid gland. Inferior pole dissection with preservation of inferior parathyroid gland, and recurrent laryngeal nerve is saved after dissection and after the right lobectomy. The nodule and the lobe that is being retrieved in a bag and retrieved to the 10 mm port. Here is the nodule, and a drain is placed in the through the 10 mm port, and there is no need to put a drain while we are performing transoral endoscopic thyroidectomy vestibular approach. So till now we have operated on 28 patients. Axillary breast shoulder approach is used in 25, and we have recently started TOETVA, and we have performed 3 cases. Right hemorrhagectomy was performed in 16 cases, left in 12 cases. Conversion to open was in 3 cases, and these were during early cases due to bleeding from the muscles. Complications, we had our share in 4 of our patients. They developed seroma formation, skin burn, and wound infections. That was managed conservatively. Mean operative time is in recent cases is almost 100 minutes. Post-operative hospital stay is 1 to 2 days. This is our study published recently at in Journal of Surgery and Research. These are few pre-operative and post-operative decks. You can see the nodule and post-operative scarless neck. This is another post-operative neck, another patient, yet another. And pictures are worth 1,000 words. You can see the difference between the open technique and the endoscopic technique, and the minimal access thyroidectomy technique. So going through the recent advances, as we talked already, that Dr. Paulo Micoli, he started endoscopic thyroidectomy for differential thyroid carcinoma in 2001. Nodes technique using sublingual approach was started in Europe in 2007. Transaxillary gasless robotic thyroidectomy in 2009 in North America. TOETVA by Dr. Anu Wong in Thailand in 2012. Transoral robotic thyroidectomy in Korea 2012, and people are crazy. They are using transtracheal thyroidectomy approach on pigs and dogs, and this was started in 2015 in Los Angeles in America. These are few recent studies about endoscopic thyroidectomy for differentiated thyroid carcinoma, this one in China. Another minimally invasive surgical technique in management of differentiated thyroid carcinoma, then minimally invasive thyroid cancer surgery being performed in America, and natural orifice total transtracheal endoscopic thyroidectomy surgery, first reported experiment in Los Angeles. So I will conclude here that minimal access thyroidectomy is a safe procedure with good cosmetic outcome. Minimal access thyroidectomy is equally good for small size differentiated thyroid carcinoma. A lot of minimal access thyroidectomy techniques have been established over recent years. Difficult, but not an impossible technique. So any questions we can ask? Thank you very much.